Hey everyone, this is Joanne and I will be talking about daycare surgery in this video. So this is lecture number 6 of the surgery lecture series. So before I dive into the topic, I would like to share a quote from Patch Adams. He said, "You treat a disease, you win, you lose. You treat a person, I guarantee you will win no matter what the outcome." So let us look at what we're going to cover in this lesson. So we will be covering some important definitions, the historical and the benefits of day surgery, the selection criteria, the post-operative complications and the discharge criteria, daycare procedures and the ERA's protocol. So these are the topics which we will be covering in this video. Alright, so let's dive right into it. So now we're going to look at some important definitions, right? So outpatient surgery means not admitted to a ward facility. Procedure room surgery means surgery not requiring full sterile theatre facilities. Okay? Surgery not requiring full sterile theatre facilities. And day or same day surgery means admitted and discharged within the 12-hour day. Overnight stay. Alright, what is overnight stay? Means 23-hour admission and early morning discharge. So now let's discuss the definition of day surgery. Okay, so this is from Bailey. Alright, so day surgery is defined as planned investigations or procedures on patients who are admitted and discharged home on the day of their surgery, but they require some facilities and time for recovery. So I told you that is they are admitted and discharged within the same 12-hour day. So minor procedures in outpatient or emergency departments, they are excluded. And in the USA, day surgery is called ambulatory surgery and it can include up to 23 hours of hospital stay. So day surgery is not a surgical procedure, it is a patient pathway. So the patient pathway is shown on the screen right now. So here you can see there's a referring doctor, specialist consultation is done, preoperative assessment after diagnostics and optimization, right? We schedule the surgery is done, and then recovery. So after doing this preoperative assessment and all of this, right, there is a method to return the patients who are unsuitable for surgical or medical reasons. So if the patient is suitable for surgery, we do the surgery and then the recovery of the patient. If the patient recovers well, we do a successful discharge, or else there can be unplanned overnight admission. So that is the patient pathway. Now let us look at the historical perspective in brief, right? So early pioneers in 1909, the Scottish surgeon James Nicoll, he operated on thousands of children as day cases. Alright, it included various procedures such as talipes correction, hair lip repair, hernia surgery and mastoid procedures. Slow acceptance. So despite the initial acclaim, the concept faced resistance. But in 1951, we have Edinburgh surgeon Eric, who pioneered day case adult hernia repairs. And hospital-based day surgery units emerged in the US during the 1960s. The first freestanding DSU, the day surgery unit, was set up in 1969. So that's all you have to remember from the historical perspective. Now let us briefly discuss the benefits of day surgery. So the patients, especially children, can benefit from shorter hospital stays and quicker return to their home environment. Uncomplicated surgeries without significant pain or nausea are ideal for day surgery. And we have financial advantages. So day surgery is cost effective, saving on inpatient bed expenses and out of hours nursing, right? But setting up these day surgery units may require additional capital and resources. Resource optimization, efficient patient throughput maximizes operation theatre utilization, and proper organization and assessment can reduce last-minute cancellations. So we should also have the day surgery units reserved for planned admissions, ensuring timely surgery. In case of patients who are unfit to go home, beds should be available. And expanding day case operations must be balanced to avoid increased complications. Waiting lists can be reduced, so minor procedures have to be addressed first. So day surgery will tackle waiting lists by addressing the minor procedures that can wait. We have patient benefits, so patient prefer going home after surgery. We can reduce the hospital-acquired infections, thromboembolism and pulmonary complications. And as I said earlier, it is ideal for children because it minimizes their time away from the family and the familiar surroundings. And care considerations, so ensure the patients are not sent home in discomfort or inadequate care. So now we will be discussing the selection criteria for day surgery. So we have the medical, social and the surgical criteria. So in the medical criteria, we use the physiological age rather than the chronological age. So the physiological age is not the age in numbers. So you can understand the chronological age is the age in numbers, but physiological age is rather the age of it assesses the functioning of the individual. Next, we look at something known as the ASA status. So the ASA status over 2, it requires careful review. So ASA 1 and 2, you can do that surgery in a standalone daycare unit, but ASA status or ASA class 3, surgery has to be done in the integrated daycare surgery center that is attached to a hospital. So you have to do it only there. That is what was mentioned here. ASA status over 2 requires careful review. And we have other criteria such as BP should be less than 180 by 100 mmHg. If it is a diabetic patient, the HbA1c should be less than 8.5 and he or she should omit the morning dose of oral hypoglycemic drugs. BMI should be maintained less than 40 kg per meter square for surface procedures and less than 38 kg per meter square for laparoscopic procedures. So BMI less than 40, but then that alone is not a contraindication. Okay, what do we have next? So epilepsy. So a well-controlled case of epilepsy is eligible for day surgery. There has to be a responsible adult to take care of this patient. All right. Okay, social criteria. So the patient should have a hospital or general practitioner access after discharge. A responsible adult must escort the patient home and care should be provided at least until the following morning. Alright, so at least for 24 hours, there has to be someone with the patient. And patients should have reasonable home conditions, so there should not be stairs, there should be toilet facilities, there should be telephone access so the patient can call the hospital in case of any emergency. So there has to be reasonable home conditions. So next we'll be looking at the surgical criteria. So in the surgical criteria, we include operations up to 2 hours and the procedures should be recognized day surgery procedures. Also the patient should be able to eat and drink within a reasonable time scale. So these are the surgical criteria that we look for. Now we'll be looking at the ASA classification. So the ASA classification, that is American Society on Anesthesiology, ASA. Alright, so there is class 1, 2, 3, 4, 5 and 6. So class 1 means normal health. Class 2 means mild systemic disease. Class 3 is severe systemic disease. ASA 4 means severe systemic disease that is a constant threat to life. ASA 5 means moribund, not expected to survive without the operation. And ASA 6 means declared brain dead. So that is the ASA classification. Now we're going to discuss about the post-operative complications. So we have major complications and minor complications. In major complications, we will see pulmonary embolism, respiratory failure, MI and hemorrhage. So hemorrhage is reactionary hemorrhage and it can be secondary hemorrhage. Reactionary hemorrhage, it is due to slippage of knot or dislodgement of a clot. Okay, and this occurs usually 4 to 6 hours post-op. Okay, so you can say it occurs within 24 hours after the surgery. Okay, now secondary hemorrhage, it occurs after 24 hours post-op. So this is within a few days. And why do we have secondary hemorrhage? That is due to infection. Another complication is unrecognized damage to viscous. So in minor complications, we have pain, we have post-operative nausea, vomiting. So post-operative nausea, vomiting is a very common post-operative complication. So to prevent that or to reduce this post-operative nausea and vomiting, we use TIVA, okay, total intravenous anesthesia. Using what agent? We use propofol. So propofol will reduce this post-operative nausea and vomiting. Okay, so we also have the Apfel score, which is used to predict this post-operative nausea and vomiting. And agents like morphine are avoided. And at the end of the case, we can give a long-acting antiemetic. Now pain, we can reduce the pain by giving adequate analgesics, and for analgesia we can also infiltrate. Post surgery we can infiltrate with bupivacaine. So this will help in reducing the pain. Okay, and I told you about the other minor complications as well. So these are the post-operative complications. Now we're going to discuss about the discharge criteria. So when can we safely discharge a patient? The patient vital signs should be stable for at least 1 hour. The patient should be oriented to time, place, and person. There has to be adequate pain control with supply of oral analgesia. The patient understands how to use the oral analgesia that is supplied. Ability to dress and walk where appropriate. There should be minimal nausea, vomiting, or dizziness. He or she has taken oral fluids. There is minimal bleeding or wound drainage. Has passed urine if that is appropriate. Has a responsible adult to take them home. Written and verbal instructions given about post-operative care, and knows when to come back for follow-up. Also, emergency contact number is supplied. So this is the discharge criteria. Now let us see surgeries which are commonly done as daycare procedures. So abdominal surgeries include appendectomy, cholecystectomy, hernia repair, diagnostic laparoscopy, and hemorrhoidectomy. So these are just a few examples. Now orthopedic surgeries include arthroscopy, Dupuytren's fasciectomy, carpal tunnel release, bunionectomy, removal of metal work, and so on. Genitourinary surgeries include laser prostatectomy, orchidectomy, vasectomy, ureteroscopy, and hydrocele repair. Vascular surgeries, we have varicose vein ablation, peripheral angioplasty. These are some of the examples. Then we have breast surgeries, so there is lumpectomy, and also biopsy, fine needle aspiration or core needle biopsy, that is done as daycare procedure. Also sentinel node excision, that is also done as a daycare procedure. So these are the examples of daycare procedures. So now we're going to discuss about the ERAS protocol. So ERAS stands for Enhanced Recovery After Surgery. What are the aims of this? The aim is to reduce the hospital stay, to reduce the post-operative complications, and to enhance the recovery of the patient after the surgery. Pretty simple, right? So this is a multimodal approach that spans across the pre-operative, intraoperative, and post-operative period. So let us see what is included in this. So pre-operative period, first is patient counseling and set their expectations. Avoid mechanical bowel preparation. Solids can be given up to 6 hours prior to surgery, and clear fluids up to 2 hours prior to surgery. Carbohydrate loading can be done. Avoid fat containing foods for 8 hours. So these are the pre-operative steps. Intraoperatively, we opt for a minimally invasive surgical approach. A local anesthetic or a long-acting local anesthetic can be given. Liposomal bupivacaine. Alright. Prophylaxis for nausea and vomiting can be given. Normothermia has to be maintained. IV fluid balance should be maintained. And these are the intraoperative measures. Post-operatively, opioids are only given for breakthrough pain, otherwise opioids are avoided. NSAIDs are given. Regular diet within 24 hours. Alright. Discontinue IV fluids within 24 hours and ambulate within 24 hours. Also avoid drains and avoid nasogastric tubes. So that is all about the ERAS protocol. So if you've enjoyed this video and learned something from this video, I encourage you like, subscribe and share with all of your friends, and keep coming back for more of my videos. So bye bye.